Hello, welcome everybody. Welcome to the re-established North East and Yorkshire HCC in collaboration with the North West HCC. Very happy to see so many of you here with us today. The session is a Teams webinar. If you have any questions for Sobia, she will answer those during the course of the webinar. But please do drop them in the chat or the Q&A and we can address those as we go. We are recording the session and we will be making that available at the end of the week. This is a web-based seminar and it's looking to educate you in a day in the life of the haemoglobinopathy genetic counsellor. And filling those shoes for us today is Sobia Khan from Bradford. There's nobody better than Sobia to introduce herself, so that's exactly what I'm going to allow her to do. So I'm going to hand over and I hope you enjoy the presentation today.
Hi, good afternoon. Thank you so much for joining me. I can't see myself and I can only see a lobby with just initials. So it seems as though I'm just talking to the screen actually. So I hope this session is insightful to you. I hope it's motivating too. I'd like to start a little bit about talking about the city of Bradford and the Bradford Teaching Hospital, and then I'll move on to my role. And I'm happy to answer any questions perhaps later on in the presentation. So just move on to the next slide. I have control of this slide. So I'd like to thank Dr. Pollard, our consultant pediatrician, for sharing these slides. She presented these slides in the peer review, which was held last year. Bradford has a population of 535,000, and we are the 5th most income-deprived local authority in England. 1 in 5 households in Bradford are food and fuel impoverished, and Bradford has the high prevalence area of haemoglobinopathy disorders as well. Next slide. So as a local teaching hospital, our services include services for children, young people, adults with sickle cell and thalassemia, and we provide haemoglobinopathy services, specialist services for diamond black fan anemia and congenital anemias, which includes those fancy words over there. We have the adult services, which is predominantly offered in a community hospital based at the Meadows. And there are 2 hospitals in Bradford, one which is St. Luke's Hospital and the other Bradford Royal Infirmary. And this provides services for children and young adults. And then we have the specialist service that we are under, which is the Leeds Teaching Hospital. And unfortunately, currently, we don't have a specialist that can support us. And that has been managed and delivered by Dr. Claire Samuelson, who joined our service in 2021. So we're very grateful for her service that she's offering. So thank you so much, Claire. The next slide I'm going to share is the number of patients that we have in Bradford. So for adults, we have approximately 53 adults with sickle cell disease, and we have 38 adults with thalassemia and rare inherited anemias. We have about 50 sickle cell children, and we have about 24 thalassemia transfusion dependent children as well. So our service has increased by 60% over the last 2 years, and that's mainly because of we have attracted many of international students who have decided to study at Bradford University. So that's given a high increase, and we predict that the number of adults are going to be increased quite tremendously again over the years. So as a local care provider, we provide the emergency and inpatient care. We provide outpatients care, including the annual reviews. We've got specialist nursing teams that support both the inpatients and the outpatients. You've got myself that delivers the antenatal and newborn screening program, and also run the support groups, which is based in the community. So moving on to me now, just talking about a little bit about myself. So I've lived and been raised in Bradford. I'm proud to be Bradfordian and have a Pakistani heritage. I worked for the specialist Bradford Sickle Cell Thalassemia Service for over 20 years. I feel blessed to be able to work and live in the community that I serve. I feel passionate about making positive changes to people's lives, whether big or small. And I worked currently with many inspirational people that have gone above and beyond their roles to ensure that they give the best possible care. This includes Dr. Minford, Dr. Williams, Dr. Kaminda, Beryl Jumna, Zabe, Mavis, and Rahana. So the Sickle Cell and Thalassemia Service was set up in 1993. And this was after lots of research and by many academics, such as Professor Medell and our local consultant hematologist, Dr. Hunt. Dr. Medell was the Wellcome Principal Research Fellow who developed the basic scientific concept of community genetics in collaboration with the World Health Organization. So I really would recommend that you read her background and how the service of Bradford came to being, actually. And so this is a link to her, which I suppose Zoe can share as well, to, what her background was. And basically what she did was that she identified the health inequalities amongst patients and their families with sickle cell and thalassemia. And that was when a pilot project was set up with the help of the local authority in Bradford, and to offer support and give informed choices to patients and their families, and to reduce the health inequalities within the community. So moving on to my role. So my role comprises of working with young people, offering them preconceptional counselling right till the end of their life, really. I'm just going to move this slide, sorry. So I'm not only involved in patients and their families, but work with other healthcare professionals, clinicians in hospital and in the community. So my role is extended to many things, such as teaching and educating, as well as supporting and counselling. I've set up support groups for adults with sickle cell and thalassemia, parents of sickle cell and thalassemia children, and transitioned patients. So this next slide is, how I started my career, and, what my thoughts were. What is it that I wanted to do? There are lots of thoughts that I had, and then eventually decided, okay, what can I do? So life really started in the maternity unit, and it's not literally, actually. It was when I was in a position where there was a woman who had a baby, but unfortunately died. And she wouldn't let go of this child. And it took a few days, actually, for the woman to let go of the baby. And that for me was really difficult, because I could see that there was a pre-med counsellor there, the interpreter was there, and nothing seemed to have worked. And the woman may have had some mental health issues, but nothing seemed to connect to her. So that was when the seed was planted for me, and I started my journey. So I took up some night school, followed by doing a degree in psychotherapy and counselling. And after a few jobs as an adult mentor working in cardiac rehab team at the LGI, I joined the sickle cell and thalassemia service. I did a few more courses at the university and at Ealing, King's College, Thomas and Guy's, and developed my role further. And here I am today. So just to talk a little bit about what counsellors do, it became quite apparent actually to me that majority of my colleagues didn't understand what a counsellor does and what their role is and the purpose that they serve. So this is one of the main reasons why I've been asked to present today, is to shine some light on the role. So counsellors, we generally are more accessible in terms of our availability because of the location and our flexible scheduling. We work in the community and acute settings such as clinics and outpatients. So this makes it easier for patients with chronic conditions to access services without requiring long waiting times or high cost specialty care. As counsellors, we are more cost effective because we're affordable. We offer flexible services, means that patients can receive consistent emotional and practical support, which can reduce the need for more expensive interventions like emergency care or long-term psychiatric treatment. We also offer practical solution-focused interventions, which tend to be practical strategies designed to help patients manage their day-to-day life with chronic conditions. This can include coping strategies for stress, communication within families, and the day-to-day challenges that are often more immediate and less intensive than the psychotherapy provided by the psychologist. Because of our short-term solution-focused approach, we as counsellors need few sessions are offered and are required for long-term. And also there's less requirement for in-depth therapy that the psychologist may offer. And this can help reduce the overall cost of healthcare providers and their patients. So counsellors are often trained to run support groups and group counselling sessions, which can help multiple patients and their families at the same time. These group settings are more cost effective than individual therapy sessions and can be particularly effective for patients with chronic conditions who benefit from shared experiences and community support. So running sessions means that a single counsellor can support many patients at once, making it more efficient using resources. And patients benefit from the shared wisdom and support from others that are going through the same situation, especially in their managing in their chronic conditions. So as counsellors, we're not only trained to provide emotional and social support, particularly in managing stress and grief, but to also focus on practical challenges, managing their care routine, navigating medical appointments, and supporting family members. So these practical interventions helped prevent mental health issues from escalating and becoming more serious, such as depression and anxiety. So by addressing these issues earlier, counsellors can reduce the need for intensive interventions and reducing the healthcare costs. So as counsellors, we often are, quite integral part of the team. Moving on to the next slide. So as a genetic counsellor, our role is that we provide lots of specialist training and also communication with the patients. We interpret the genetic results and also help to assess genetic risk to individuals and their families making those informed choices about their health. Our role not only goes beyond delivering genetic results, but it also involves helping patients understand implications of the results, discussing potential outcomes, exploring options, and offering emotional support. So our training is not only to do with understanding genetic haemoglobinopathies, but the risk assessment of and the psychological aspect of genetic testing and how to communicate complex information in a compassionate and understandable way. I'm just going to get some water if you don't mind. Okay, so the ethical and psychological considerations. So as counsellors, we help individuals process how genetic test results might affect them personally, socially, or emotionally. For example, if a genetic test reveals some genetic carrying genes for a hereditary condition, the counsellors help them to understand the risks and consider family planning options, how that information might affect their family members, and how to cope with the potential psychological distress. Health professionals who are trained as counsellors may not be equipped to handle the emotional aspects of the kind of information or to provide the psychological support patients may need, such as dealing with guilt, fear, or anxiety related to the test results. So as an essential role, it's providing not only genetic results, but also we specialize in explaining implication of genetic results, helping them to make informed decisions and offering them the emotional and psychological support. So we're almost like a satellite navigation system where we help the patients to move into another territory and unknown territory, but are there to support them. And we're also a part of, the team, the MDT, our genetic counselling, focusing on supporting patients through their decision-making process, but also to help the healthcare professional to manage the patient and, to help them to follow up their care. So not only is the MDT comprises of the main professionals such as the nurses, the doctors, the psychologists, but we feel that the team can include teachers, youth workers, and psychotherapists and benefits advisors, as we have. We have a benefit advisor in our team, but we don't have the others, the youth worker and the psychotherapists and the teachers. That would be really beneficial. So I just want to move on to a case study. As I mentioned, that there are many people that have moved into Bradford, and many that have come from Nigeria. And many people from Nigeria are genotyped before, at an early age, at school perhaps. And I just want to talk about a young couple that came to Bradford. They fell in love, got married, and decided that they wanted to make start a new life, and decided that they wanted to study in Bradford. So the world was their oyster, and they chose Bradford as the starting point. And after a couple of years, they decided that they wanted to have a family. So the young woman became pregnant and had the antenatal screening program. Went through the antenatal screening program and had the screening test done. And it was highlighted that she was a carrier of sickle cell trait, which she knew about anyway. But following on from the antenatal screening program, the next step is to test the partner. So as usual, we tested the partner, but unfortunately for them, he too was a carrier of sickle cell. So they are known as at-risk couples. So unfortunately for them, they became the at-risk couples for sickle cell disease. And we had to tell them about the position that they were in. Counselling was offered, and as usually the case is that we offer a PND, and that was offered to them. Unfortunately for them, and once the PND was offered, the baby was found to be having sickle cell disease. So they were in a lot of anguish, lot of dilemma, and really weren't sure what to do, but decided to go ahead with the pregnancy. And because of the fact that they weren't quite aware of what sickle cell disease was, and they were praying and hoping that perhaps once the baby was born, it wouldn't be the case. So we in Bradford, soon as the baby is born and they're picked up through the newborn screening, the babies are referred to the consultant hematologist and the pediatrician. So the Dr. Pollard picked this couple up, and they were referred at about 3 months. And so the baby had a repeat test then. So far, the baby's doing well, the family's doing well, and really happy. But only a few weeks ago, actually, she was pregnant again, and she got in touch. Again, we offered her PND. Unfortunately, again, with this couple, the baby is affected. And this time they've decided that they're going to terminate. And it was only yesterday that we got the results. And they've decided to go ahead and terminate. So it is quite difficult for them, because unfortunately for them, the lady is about over 16 weeks, and that's going to make it much more difficult for her to manage. So I think that's one of the case studies that I would like to present. I think that's about it. I don't want to go any further, but just explore perhaps the future. What do you think sickle cell, as a sickle cell service we can offer, and as genetic counsellors we can offer to the wider HCC group? Is there anyone that would like to ask any questions or suggest anything? If not, that's absolutely fine. Zoe, are you there?
Hi, Sobia. Thanks very much. Thanks very much for your fascinating presentation there. We have got people that are putting their hands up. So just to make people aware, if you're putting your hand up, I'll free your mic to allow you to ask the question. And just to mention, obviously, it's being recorded. So I will go ahead and I'll allow the mic. If people would like me to allow the camera as well, I'm happy to do that. But initially, I'll just allow your mic. So Lindy Defoe is the first person to have a hand raised.
So hi, yes, thanks, Sobia.
Hi,
that was
Maddie.
really, really interesting. I'm just wondering, because we're like you, I think a lot of the hospitals in the North East, we've had a big influx of students arriving, which has increased our numbers, massively. We have a real problem with people coming over predominantly from Nigeria who are under the impression that their genotype is AA, and they arrive with us pregnant, or get pregnant, have the baby, and the baby's picked up as a carrier, and on retesting obviously they come up, they're not AA, their genotype is AS, and it's causing considerable problems with both the antenatal screening coordinators and myself as the newborn screening coordinator. And I just wondered whether you've come across similar problems.
I suppose we're in a fortunate position, and I wouldn't mind Claire helping me out in this if she wants to. So we are fortunate in Bradford because I'm the one that offers the antenatal and newborn screening. So I see the patients right the way through. So anyone who has been picked up through the antenatal screening program will be picked up by me. So I would make the initial contact, give a little bit of background about the screening policy and pathway. So they are quite reluctant and are kind of shocked at why it's necessary. But I say that, we need to do the test here in Bradford just to confirm. And they're happy to go along with that. And then at that time, when I've done the antenatal screening and have counselled them, I do make them aware that we will be doing the newborn screening program. So as long as we communicate clearly, so I appreciate the fact that not every region has myself as a person that coordinates the antenatal and newborn screening program. But if we communicate and have a good communication link, I suppose it still can be delivered. So I make them aware of each step and process. And do inform them that unfortunately there have been cases where the results have been misdiagnosed, and that was something that was brought up in one of the UK forums of why this is the case. Does that answer your question?
Yes, it does, and I completely agree. I think communication, every point is vital. Just from experience, I mean, if the antenatal coordinators, have a particular issue, they will contact me to get involved at that point. But we had a couple very recently who, I mean, were very adamant, even when we showed them test results, retested, that couldn't possibly be a carrier. And unfortunately, the baby has been born with sickle cell disease. And with the best communication I think we're giving them, it's been really, really hard. And we always get asked the question, why are my results in Africa? I've been tested several times, I've been told from birth that I'm AA. Why is this all different? And I just wondered if we can ever kind of highlight what actually goes wrong out there. Is it just communication? Are they testing differently? It is a common problem. It's not an isolated incident. It is a common problem. But yeah, when you've developed that relationship with a couple, both right from antenatal screening, it definitely makes a difference, I think. But this recent one was absolutely heartbreaking for them because it took a long time for them to accept both their screening and the ultimate, unfortunately the baby being born with sickle. And I think they are still struggling. When I speak to the family, they take the labels off the medication. They don't want any family knowing that the daughter's on medication. They haven't told anybody. They're just completely keeping it to themselves, which is
so sad. Yeah,
really sad. Yeah. I
Um,
don't know if you would offer anything else you could possibly do. I'm hoping that time will bring them
Time
round
does
a bit.
heal, but like I mentioned, my role as a genetic counsellor, I'm offer them counselling, and I think that's another healing step. As long as they are offered counselling and support, and the support group also is really valuable. But that's in time. It all depends on the couple, the individuals, how quick they come to terms with it. And it's not, how quick really. It's about how they feel comfortable. It's about going with them and making sure that they feel reassured and are supported, because having a child with a condition is a long-term issue, and you just have to go with how they feel. So you're doing a great job. Being on your own, it is difficult. I feel that I've been blessed with such a supportive team, such as Claire and Dr. Pollard, and the CNSs. So we can share the burden really. So Claire, is there anything that you would like to add? Sorry, we can't hear you. Why is it we can't hear you? No. Oh,
Is that not working?
do we?
Yeah.
Yes, it is now.
Yeah. Okay, great. Thank you, Sobia. Thank you for such an excellent talk. That was fascinating and inspiring, and certainly working in two regions, one where we have you and in Sheffield where we don't have a community service. I can see the huge difference that makes to our patients and patient population. And one thing I would love to hear more about is I know that you do a lot of work raising awareness in the community and at freshers fairs and going out to schools and colleges, and I think it'd be great for everyone to hear more about that, because we've talked about how difficult it is for a couple, maybe once there is a pregnancy, to find out that there's a risk of baby being affected, and therefore how important it is for people to have screening before conception, or dependent on their views, potentially even premarital screening, and it'd be wonderful to hear a bit more about the work you do in that area.
Certainly. I'm just aware that the last question was about it's not isolated. The results from Nigeria are usually misinterpreted, aren't they? Can you give a bit of background as to why they're misinterpreted, or why they?
Of course. So I agree with Lindy, and I think this is something that's seen across the UK, is that people are sometimes coming from elsewhere with misdiagnoses, and there are various patterns. One thing we've seen a lot of is people told that they are AS, so sickle carriers, when actually they have SC, and I think that may be wherever people are seeing two peaks on their haemoglobin separation technique. It's being interpreted as AS rather than SC, but we've had misdiagnoses in every direction. We also had one person who was told they had sickle cell, and actually they don't. They're a carrier, and they found that very difficult to adjust to as well. I think it's difficult for us to know exactly why results aren't accurate. We know all of the sort of the quality assurance, quality control measures that go into making sure our results in the UK are accurate, and we don't have control and information on the various laboratories that are offering testing outside the UK. So I would agree with the comments that even if someone has had screening elsewhere, we certainly want to encourage that to be repeated. It may be a question of the test being less accurate, it may be to do with the interpretation. We just don't know, and there's the issue of accuracy, but also the scope of testing. So it might be that people are having a test looking for sickle cell only, a sickle solubility test, for example, but they're not actually having a test that would pick up a risk of being a carrier for beta thalassemia, which would require the A2 or the F level, for example. So I think even if someone feels very confident that they've had screening or repeated screening, I think I would always encourage people to have a repeat once they're in the UK. And similarly, if someone's partner is being tested outside the UK, we would just recommend that that's done here. One obstacle we've encountered is people call screening different things, don't they? So sometimes people say, I've been to my GP and asked for a genotype, and actually the GP maybe didn't interpret that in the way that we would interpret it and said they couldn't do it. So I think just kind of talking about the language that people are going to use when requesting a test can be really helpful as well, because of course that is something that should be available via the GP in primary care. It may just be sort of we're not asking in a way that's understood quite as readily.
Thank you. So you were asking, so we here in Bradford, we do offer a family screening and also self-referrals, so anyone can actually walk in and get screened. So we're fortunate with that. In terms of raising awareness, I'd like to, we've always, as a specialist sickle cell thalassemia service, done lots of raising campaigning, and that's worked really well. So not only in the schools, but in the community, local community settings, and that's just about raising awareness and talking about the fact that it's a simple blood test, and can, avoid so much anguish and heartache. And people are really receptive to that. If we open it up and talk to them and relate to, you know, different scenarios, it really becomes, you know, a very positive thing rather than a stigmatized, you know, situation, because we know that in many cultures, including the Pakistani culture, we have cousin marriages. So it's really difficult, usually for health professionals, to engage in that conversation. So going out into the community, making them aware of, you know, that it's not only to do with cousin marriages, there are other implications. So I think it's worked really well. And when I started my role, I was really lucky to be supported by the consultants. So the consultant pediatrician, Dr. Winford and Dr. Williams, they both came along to the schools, and that was raising the awareness. And the young people were there, able to ask questions directly to them. So it was really wonderful to see that the clinicians were on board and found it valuable to raise the awareness in the community. So sorry, I've taken so long for just the one question, but is there anyone else?
Thanks, Sobia. No, I think that it's great. It's absolutely perfect for you to take the time. We're obviously very keen to hear your thoughts. Could I perhaps just ask if you can try stop sharing screen? I think there might be an option at the top of your screen. It just says stop screen. So okay, while you're looking at that, and then we have another question from Jessica, who I've allowed your mic, Jessica. If you'd like me to share your video again, I can, but for the purposes, you should be able to ask your question.
Oh, hi. Thanks so much for this talk. It's really helpful and very timely for us in Southampton. So I'm a genetic counsellor in Southampton covering the Wessex region, and we are a bit like you guys, seeing an increase in the number of referrals. So I just have a couple of questions, because I don't feel that there's a very clear pathway of how these couples should be managed. And I think it's great that you have this, what appears to be a unique role to you, where you are a genetic counsellor specialising in the thalassemias and sickle cell. For us, it's slightly different. And what tends to happen in where we work, and I work predominantly in Portsmouth, is that we ask the GPs to manage this, and the only time that they are seen through a clinical genetic service is when they are being referred for pre-implantation genetic testing. So this is when we know that two individuals are both carriers and they want to avoid a pregnancy. So that's affected, and so they go for PGT. And one of the things that I would like clarified, and I think that perhaps you've answered this, is because if it's a carrier couple who just want testing during the pregnancy, the midwifery team will manage that. And am I correct in thinking that when they do that CVS or amnio, they are doing the same test? So they're not genotyping in the way that we would talk about genotyping. So they are not sequencing the genes that can be associated with thalassemia or sickle cell. They're doing that same electrophoresis test, but on a CVS sample or an amnio sample. Is that correct?
So I think so. That's the right thing. There's someone in Sheffield that can correct me in this. So we offer a separate sample testing for.
Oh, am I the only person that has lost sound?
No, I've lost Sobia as well.
Sobia's frozen, unfortunately.
Oh no.
Just while Sobia's getting the IT back. Nice to meet you, Jessica.
Hi.
Can I come in and comment on that?
Yeah.
In the prenatal testing, you don't have access to fetal red blood cells, so it is genetics.
So it is genetics. So you are sequencing those genes.
Yes, so if they're looking, so they can obviously go in and just look specifically for the sickle mutation, can't they?
Yeah.
Or, you know, where we know the beta thalassemia mutation. I don't think they're necessarily, you know, sequencing the whole, you know, HBB gene.
Yeah.
It is a genetic test rather than a hemoglobin test, because of course, you know, we can't get the fetal red cells, but
Of
also, you know,
course.
hemoglobin is a different type of hemoglobin earlier in prenatal life.
Yeah, I'm, you know, I feel so ignorant about this, and I feel dreadful that I'm so ignorant about it. I am really trying to educate myself, because I do feel that we are getting more and more people who are referred in this situation, and it doesn't feel that there's a consistent approach. Whereas if this was, for example, cystic fibrosis, everyone would know what to do. And I just feel dreadful that we don't really know what we are meant to be doing, or there's no consistency in how we do this. So I think the other thing that's quite difficult for us, and I would love to hear your expert opinion, is that when we refer couples for genotyping, because they want to have PGT, we have to supply quite a lot of information. So the electrophoresis carrier tests, which we don't always have access to because GPs are doing that. Is that something that it feels completely necessary to you? Is that something that should be in our pathway?
That's a good question. So if the couple's at risk of having a baby affected by sickle cell or beta thalassemia, you're right. The parents, the carriers, will have been detected by usually HPLC or capillary electrophoresis, so hemoglobin separation method. So they probably just want to verify that you know, those results are right. And that's not unreasonable. And I'm not sure about the local IT systems, but I would hope that you know, the clinical team could access results done by the GP.
Sure.
They'd normally be just reported on a simple, you know, iSystem or something like that.
Yeah.
Alpha, for a risk of alpha thalassemia, you know, if you're worried about the alpha naught chromosome, that can only be done by genetics. Again, it's going to be dependent on local pathways. I know certainly for us, GPs won't be sending off those genetic tests, and they will have to go into either clinical genetics or hematology to have those done in the first place. But again, we don't have, you know, a robust pathway really in a service set up to see people who are carriers for that level of counselling and testing, which is why I think Sobia's role is so important.
Yeah, absolutely.
Yeah, so it's a you know, it's a gap in the service. And I will try and see at-risk couples where they're referred, but that's not really what our service is set up to do. I think, you know, everyone should have a service like the one that Sobia offers. Nationally, though, it is a real gap, and I think, you know, we've got national programs for neonatal and antenatal screening, but as Sobia's highlighted so well, actually, if we only pick up that a pregnancy is at risk of being affected once someone is pregnant, that then leaves a couple with some very difficult decisions to make. And some people, dependent on their personal religious and ethical views, wouldn't want to consider terminating an affected pregnancy. And it feels as though that's too late to pick up the fact that the couple's at risk, and they've missed the opportunity for pre-implantation genetic testing on that occasion. I really think that nationally there should be another point of screening, maybe, you know, older childhood, younger adulthood, where people are going to be tested for screened for carrier status and given that information, because the neonatal screening will pick up sickle carriage but not beta thalassemia carriage, for example. Equally, we don't know whether those children and young people are given the results as they grow up. You know, the results are given to parents. We don't know what happens to them. And so I think nationally that is something that we're lacking and that could be done better. And it sounds as though, you know, you're very much feeling the effects of that in Portsmouth as we are as well.
Yeah, I just, you know, you just want to give people the best service, and like you say, that opportunity so that they aren't in that situation where they are carrying an affected pregnancy when that could have all been avoided. It just seems so unfair.
Yeah.
And yeah, I'd be really interested to know how that will ever be resolved. It's tricky.
Yeah, it is. I know that the UK Thalassemia Society have raised with NHSE the need for an additional screening time point. I'd certainly be very, very supportive of that. Maybe when people are still at school, finishing their education around the time of those additional vaccines, 15, 16 would be a really good time point. I think it's about giving people the information to make informed choices for themselves rather than finding themselves in an unexpected situation.
That's brilliant. Thank you so much for your insight. That's really helpful.
All right, thank you very much. Hopefully Sobia's been able to rejoin. Sorry, IT is the bane of everyone's life, isn't it, now we're all on Teams for everything.
Thanks, Claire. No, sort of off the line, we are trying to get Sobia to join. This is actually her at the moment. I will just take this call and hopefully get her back on the line. Just bear with me 1 second.
Just while we're waiting, it would be really interesting to hear from anyone else that works in a community service about how your service is set up. Any ideas for good practice? Any challenges to share? Because we do know that across the country, even though all of the specialist haemoglobinopathy teams should have community services, not everybody does.
Hi, apologies, Claire. I'm not sure how you want to proceed. Unfortunately, Sobia, she's not able to rejoin. We've sort of resent the link a few times, but for whatever reason, we're having real technical issues getting her to sort of back on the call. I guess we can either sort of proceed with the questions if we can answer them, or perhaps we can, if people want to put the questions in the chat or the Q&A, we can ask Sobia to have a look at that, perhaps offline.
Right. Yeah, I think it'd be great to hear people's questions, and I was also thinking it'd be really, really useful to hear other people's experience of community services as well.
In that case, the next person that has a question, I believe, is Palmer. You've got your hand raised. Apologies if I've not quite pronounced your name correctly.
That's okay. I'm not actually Dr. Kumani Palmer. I'm in disguise because my login didn't work for the meeting. So my name's Sarah Barnes, and I'm the sickle cell and thalassemia nurse in Leicester, and I'm the lead for antenatal and newborn screening. So I do a lot of preconception counselling all the way through to newborn screening. So it's been really interesting listening to people, and I actually put my hand up first of all because I was going to add something to the first question, but by the time actually we've come around, Claire's answered most of that about the people were saying about sorry, I didn't catch the first lady's name, about why we're getting discrepant results from people arriving overseas. And yes, we experience that all over the country. Definitely, we have a lot of that. I have a daily clinic for antenatal carriers, and we frequently have people who think they're AA turning out to be a carrier of something else. Often, hemoglobin C, because the testing overseas is just looking at sickle testing, isn't looking for hemoglobin C or beta thalassemia. But also because access to clinics in places, things like that. If you think of the vast difference, I think Nigeria was mentioned, where 1 in 4 in the population is a carrier. You've got some people living around Lagos in the big cities where you've got access to clinics and things like that. But actually beyond that, healthcare is very different. So yes, that's definitely a national picture that we're all seeing. We're all seeing the increase in our numbers. We're all seeing discrepant results and the heartache that causes, particularly when people have done the right thing and had their genotyping done before they get married, because that's the requirement in Nigeria, and it hasn't produced, it hasn't actually been an accurate result. So that's what's, and the other thing I was going to say is it's not just Nigeria. People are talking about this, obviously numbers are changing, and I think the populations for screening is changing. My sort of caseload for people with beta thalassemias and things, carriers like that, has significantly changed with the populations that are coming over from Syria, Afghanistan, Iran and things like that. So I think whereas the population demographics were a certain mix sort of 10 years ago that were, you know, you had people from Africa, Caribbean, you had people from Africa, you had people from Cyprus, you know, I think it is changing who we are seeing in clinics most definitely now, which also has implications for our resources in different languages and things, because we're definitely seeing different communities now. The other thing I was going to say was and answered, oh yeah, not just it's private clinics as well, where people are having testing done. Like you say, everything in the UK is done by the UK accredited laboratories, so we know we can trust it. And I think basically at one time we used to accept results from abroad if they'd got an FBC and if they'd got a HbA2 and things like that. But I think now it's sort of, you have to question even those, because actually it's not necessarily, as a screening program, we're saying about risk, and we should be saying about risk from a result that we know is reliable, from a UK accredited result. So I think it's important to sort of think about that. I had a baby with sickle cell born whose parents had PGD privately and through a clinic in Los Angeles. And no, you're not, your baby's not going to have sickle cell. You know, this was a doctor that had been over and had, you know, all the tests she thought she should have, and still the baby had sickle cell disease. So I think it is very much think about, we know what we can trust, and what we can trust is UK accredited laboratories and things like that. Also, so then jumping on to the questions about how services set up, and that Jessica was just talking about different in different places. So within our team in Leicester, we have adult haemoglobinopathy nurses, we have children's haemoglobinopathy nurses, and there are a couple of us who are in a service that used to sit in the community. And one of those sort of when those community services seem to start disappearing and were being brought in amongst the sickle cell teams, we are a team that predominantly does screening. So we do the antenatal screening, we do the newborn screening. We also, since sort of genetics were sort of dropping things over to us and things, we've casually picked up a lot of stuff about preconception fertility stuff. We've picked up preconception counselling, and that is on the increase as well. The problem with it is that, as we're sort of seeing now, is these services aren't funded, so it's hard to say what you're doing when it's a service that's not commissioned and things like that. So I think that's the issue, it's not specialist commissioning, but it's also the community commissioning is saying you're in a hospital service, so it doesn't necessarily fit there either. So I think there are big issues with that need unpicking, but everything is different in each area because every service is different in each area. So I would do, it's me, not a midwife that does the antenatal screening here, myself and my colleague Rachel. It's me that offers carrier couple counselling. It's me that offers PND. It's me that will give the PND results. If a family want PGD, I do the carrier couple counselling, the preconception counselling, but I still refer on to the genetic counsellors, because actually it's only the genetic counsellors that can make a referral to the specialist centres, like Guy's and Thomas's, for the PGD. As a haemoglobinopathy nurse, it's not enough. It has to be the genetic counsellor. So that's why the referral will still end up coming to you, Jessica, for because it needs to be clinical genetics referral.
Thank you. It's really valuable hearing the insights for people's experiences sort of across the UK. Thank you very much for sharing. I'm very conscious we've still got a couple of other people that have got questions, and we are obviously running out of time. I'm quite happy to keep the meeting going on, but I suspect there's quite a few that probably will need to drop off. So I just want to take this opportunity to say thank you very much for joining us today. We do have another webinar that's taking place next month. The webinar is Improving Nutritional Management in Haemoglobinopathy Patient Care, Exploring the Challenges and Closing the Gaps. And we've got another fabulous speaker in Claudine Matthews, who's a consultant dietitian in health and social care. I'm going to drop the link for you to register. So it's exactly the same process as what you did for this webinar. So I'll drop that in. But for now, I'm going to hand over to Lisa, who's going to hopefully try and squeeze in her question or her thoughts in the 2 minutes we have left, and apologise for sort of rushing ahead. Lisa, I've allowed your mic and I've allowed your camera. Feel free to share either or both.
Hello, I'm Sarah. I'm Lisa's colleague, so I'm based at the Royal Berks Hospital in Reading. I'm one of the screening midwives. Apologies if we missed this earlier, because unfortunately we were stuck in a fetal medicine clinic, so we only joined halfway through. But we were quite interested if anybody could give us any information about the new gene therapy treatments for sickle cell and beta thalassemia, and how is that actually, because it's in NICE guidance, isn't it? So is that actually a current treatment, and how should we be counselling our women about it? Can anybody shed any light on it?
Hi Lisa, hi, nice to meet you, thanks for joining. So probably just briefly, the genome editing treatment from Vertex, the Exocel treatment, or Casgevy, the trade name, has been NICE approved. It's going to be a managed access program, so that's not necessarily going to be guaranteed to be available long term, but while they're collecting more long term data. And again, we're just waiting for all the details of sort of the national eligibility criteria and pathways, but they're likely to follow those from the clinical trials. People with more severe sickle cell disorder, age 12 up. In the clinical trials, people were treated up to 35, but I'm hopeful there won't be sort of a definite cutoff at 35 in the licensing. Certainly doesn't look as though that will include that. People who are fit enough, of course, to go through what is essentially an autologous stem cell transplant, so high dose busulfan therapy. So I think in terms of counselling parents of people, of babies who might be affected by sickle cell disorder, you know, there may be the potential for curative treatment, either a donor bone marrow transplant or gene therapy, but that's not going to be the route followed for the majority of people, I think, at least at the moment.
So it's still just all in clinical trials. It's not actually been agreed for treatment yet.
Yeah, so it's out of clinical trial, trial, and approved by NICE for a managed access program. But we haven't actually started treating people on the NHS as yet.
Right.
The experience we have comes from clinical trials, but it is now available and funded by the NHS for people who will meet certain criteria. But it's not a panacea. It's still very high dose chemotherapy and the drawbacks that entails. And the other thing to say, it's disease modification rather than cure as such. It doesn't way the sickle cell, it increases the fetal hemoglobin in a longer term manner. But for people who say have had a stroke, you know, where we know that just increasing fetal hemoglobin with hydroxycarbamide isn't good enough for them, isn't as good as regular transfusion. There will be still some people who I think we should be looking at a donor transplant rather than gene therapy for, if we are going down the route of long-term disease modification rather than ongoing treatment.
And will it be available sort of nationwide or only in particular areas to start with? So
it's been approved by NHS England. The other UK nations tend to follow NHSE's lead when new treatments are approved, but I can't comment on the current availability in devolved nations. They've initially commissioned 6 treatment sites in England, Manchester, Birmingham, and then the other 4 are in London. But people from anywhere in England would be able to access one of those sites. So the whole of the north of England is currently covered by Manchester, for example.
Okay. All right, that answers some of our questions, I think. Thank you.
Thank you.
Thank you very much, both. I believe Sobia has actually been able to get back in. Sobia, I don't know if you are able to share screen.
Hi.
Hello.
I
Hi.
do apologize. Technical issues. The phone had decided to reboot again. Rather the laptop decided to reboot again. So I do apologize. Thank you so much, Claire, for helping me out there. I think we ran out of time, haven't we, Zoe?
We have. I think everybody really enjoyed your presentation. Obviously, it's a shame we've had those few technical issues, but I think we've had a successful webinar there. So just to say thank you very much, Sobia, for all of your time and efforts today. It's been very much appreciated. Thank you very much. And we'll look forward to hopefully seeing some faces from here at our next webinar next month. But yeah, thanks very much to everybody, and enjoy the rest of the day. Thanks a lot, guys. Bye-bye.
Thank you.